Now we move on to Daisy Halligan, who's another PhD fellow, and this time she is from this institute itself. Now, Daisy has been wondering about those practices that are a bit like the Cheshire Cat's smile, the ones that persist for a very long time, long after they should have disappeared and gone away. Daisy, tell us more.
Hello, my name is Daisy Halligan, and I'm a second year PhD student based at the University of Leeds and the Yorkshire and Humber Patient Safety Translational Research Centre. My project is entitled Identifying, Understanding and Stopping Low Value Safety Practices, and it's funded by this institute. There is increasing recognition of ineffective healthcare interventions and systemic waste in the NHS, with evidence suggesting that up to 30% of all healthcare provided is unnecessary. Waste in healthcare encompasses any low-value practice which, according to NICE, can be defined as A, not being clinically effective, B, having a poor risk-benefit profile, or C, not being supported by adequate evidence. Some examples of procedures that have been removed from healthcare in the past due to these reasons include imaging for back pain and the use of antipsychotics in older patients. With the NHS currently experiencing an acute lack of time and resources, it's becoming more important to identify potential practices for de-implementation. Previous strategies, such as health technology assessment, have been driven by external policymakers and commissioners employing top-down strategies to decide which practices are least cost-effective and have then developed guidelines to discourage healthcare professionals from their use. This approach has proven difficult to implement in the past because dissemination alone is not sufficient to ensure behaviour change, and so other strategies and incentives are required. My project is using a different approach that involves working with healthcare staff to identify potential opportunities for disinvestment, such as practices that do not result in benefits for safety or simply are impossible to implement. During the first year of my PhD, I disseminated a survey on hospital wards via social media, which asked healthcare staff to identify practices which they perceived to be a waste of time because they don't make care safer. We received responses from 526 healthcare professionals across all NHS regions and conducted content analysis to identify recurring practices within the data. We calculated the most frequently mentioned practices and then grouped them into categories. The most commonly mentioned categories of practices included duplication, for example, double-checking medication, blanket policies, such as skin pressure checks on independent patients, risk assessments, including falls risk assessments, and ward rounds such as intentional rounding and incident reporting. We then went on to do a thematic analysis of reasons that practices were perceived to be low value. These included the theme of covering ourselves, where healthcare professionals identified some administrative safety practices, such as a waste of time, because they take healthcare staff away from providing direct care in order to produce evidence of completed clinical tasks, such as safety checklists or intentional rounding. Additionally, we identified the cross-cutting theme of not my job, where healthcare staff highlighted that carrying out tasks which are not part of their formal job role is a waste of time because it takes them away from their own caring duties and responsibilities. For example, one healthcare professional mentioned that it's a waste of time for nurses to be washing equipment and the environment. Therefore, whether or not a task is perceived to be a waste of time can depend on who's carrying out the task itself. We placed the 9 most frequently mentioned practices into a shortlist and began a 2-round Delphi procedure in which a panel of healthcare experts were asked to rate the practices on criteria such as resource use, feasibility of the implementation, and how anxious they would feel about no longer carrying it out in healthcare settings. Based on the results from the 2 rounds, 5 practices were removed from the shortlist based on issues of specificity and not being able to comply with national policy. I'm now conducting further research to learn about the underlying evidence and policy surrounding the remaining 4 practices. In addition to this, health economic evaluations will be conducted to learn what the potential financial implications of removing the practices could be on healthcare. It's hoped that this information will help us to determine which low-value safety practices to focus on moving forward. Once a target practice has been identified, the next stage of research will involve working with healthcare experts and policymakers to learn more about the practice and what the consequences of removing it could be on patient safety and healthcare professionals. This will be enhanced by a systematic review that I'm also conducting, which is synthesising previous research that's implemented interventions designed to stop healthcare professionals from carrying out clinical or non-clinical tasks. We are currently working with colleagues at the University of Technology in Sydney to replace the initial survey, replicate the initial survey, asking healthcare staff to identify practices they perceive to be a waste of time. Our Australian colleagues are also asking a question about what healthcare staff do to work around these low-value practices. To date, this survey has around 360 responses, and we're aiming to reach 500 by the end of the year. We very much are looking forward to learning how the healthcare professionals' responses compare when the study is replicated in a different country with a different healthcare system. Thank you for listening to my This Space mini talk.